Welcome everyone, and thank you for joining us today for our webinar titled Doppler Flow Velocity Measurements for Cardiovascular Research. This is Martin Hess from Inside Scientific, and I will be your host for today's event. We are looking forward to an exciting session today, sponsored by Indus Instruments, that will highlight the use of Doppler flow velocity measurements for cardiovascular research. Earlier this year, we hosted two webinars focused on this technique. Webinar 1 was an introduction to the Doppler flow velocity technology and provided an overview of how it can be utilized for some of the more common cardiovascular research applications, while webinar number 2 focused specifically on the use of peak aortic flow velocity as a surrogate to measuring dPDT to assess cardiac contractility. I would encourage all of you who did not attend those sessions to visit our website and view them on demand when convenient. Today, during session 3, we will answer your questions about how to apply this technique in your lab, as well as provide any technical information that you have asked about. During the registration process, you were asked to submit one question to our guest speakers to answer. We use those questions as a foundation to prepare today's presentation content. Our speakers for today's webinar are Ms. Tanya Coulthard, Product Manager at Indus Instruments, and Dr. Anil Reddy, Assistant Professor of Cardiovascular Science at the Baylor College of Medicine in Houston, Texas. Tanya has a background in biochemistry and experimental medicine and has worked with researchers around the world in a wide variety of disease areas, including cardiovascular disease, for over 10 years. Tanya works with customers at Indus Instruments to understand their specific research applications and to better align product capabilities to their needs. Dr. Reddy has been developing Doppler and physiological signal acquisition and processing systems in collaboration with Indus Instruments since 1997, many of which are currently being used in his lab at Baylor College of Medicine. Dr. Reddy's research interests include evaluation of cardiac and vascular mechanics in senescent, disease, transgenic, and surgical models of mice. Using non-invasive methods in his lab, he phenotypes animals as abnormalities develop and monitors the cardiovascular system as it adapts and compensates for either deterioration of function or for missing or overexpressed proteins. The main goal in Dr. Reddy's laboratory is to translate what is learned in mice to humans for early detection and screening of vascular diseases.
Thank you everyone else for taking the time to join us today in learning a little bit more about the Doppler flow velocity system from Indus. I will be speaking for most of the time. However, I will call on Dr. Anil Reddy throughout the presentation to help me address some of the specific questions that you have asked during the registration. So today's webinar is a little bit different than the other two that we've done previously, as Martin was describing, in that we asked you to submit questions during the registration. Now, as Martin mentioned, due to time, we don't have all the time to address each question, but we will follow up afterwards with responses to each question, and this will be circulated to everyone who registered for the webinar. I will begin today with an introduction and overview of the Doppler flow velocity system, and then next we'll spend some time discussing how the Doppler system compares to an echocardiography system as to address a specific question that was asked. And finally, we'll finish up with some time discussing specific applications of the Doppler system related to, again, questions that were asked during the registration. These will include cardiac function, coronary flow reserve, vascular injury, and pulse wave velocity. And finally, we'll finish up with a discussion on peripheral vasculature. During the first part of the webinar, the presentation will respond to a number of questions that came in with regards to the basics of how the Doppler flow velocity system works. In answering these questions, I hope to provide you with an introduction and overview of the system. I suspect that most of you are working with rodents, as Martin confirmed with the poll responses that were presented or were provided earlier, or other small animals within your research. This is mainly because a wide variety of genetic and surgical models which have been developed within these rodents. And of course, it is important that we be able to phenotype those models, which is the main goal of Dr. Reddy's lab at Baylor. Many of these measurements or parameters that we're looking for are a function of time, and thus high temporal resolution waveforms are needed. And you'll see exactly how the Doppler system is able to do this. However, the main challenge in phenotyping a model is to remain non-invasive, so that the same animal may be used as its own control over the course of a longitudinal study. This helps to reduce variability in the measurements, reduce the number of animals being used to complete a study, and overall improve the outcome from your study. As you will see, the Doppler flow velocity system is primarily used for non-invasive studies. We talk a lot about using mice and rats in basic research. However, there are a wide variety of other similarly sized animal models which we have used with the Doppler system. These include, but are not limited to, naked mole rats, bats, even zebrafish, and amphibians such as frogs. All of these animals may be assessed non-invasively, as the probes have a 1 centimeter depth of penetration. For larger species, as well as those mentioned above, we do have silicone cuffs which may be surgically implanted around the vessel of interest. This allows the Doppler spectrogram to be obtained on large rodents, mammals, and even non-human primates. Once the cuff is implanted, the data collection is completely non-invasive and reproducible over the course of your study. Data for all species may be acquired on anesthetized or conscious animals, with the obvious requirement that the animal remain stationary with respect to the probe during acquisition. When using the non-invasive probes, we have had success scruffing the animals. This is of course best done on a trained animal to avoid any increase in the heart rate or blood velocity that may be caused by stress. Likewise, if an anesthesia is used, the choice of which one to use is equally as important as to not decrease the heart rate or blood velocity. As you will see in a few slides, we also include a heated platform to help maintain the body temperature of the animal during the acquisition. As well, this platform helps us to monitor the ECG signal along with the heart and respiration rates. So a bit of the Doppler basics for those who may be less familiar with the principles involved here. When we acquire a Doppler spectrogram, we place the probe on the surface of the skin, and it sends and receives pulses of sound. We know the frequency of the pulse which is sent. The sound is then reflected off of various structures. In this case, we're specifically looking at the reflection from the moving blood within a vessel, or specifically the erythrocytes within the blood vessel. When the sound is reflected, there's a shift in the frequency of the sound that is relative to the velocity of the blood. We call this the Doppler shift. When calculating the velocity of the blood moving, we must take into account the angle between the Doppler probe and the blood moving through the blood vessel. This is theta in the equation that you see here. As you can see, the equation does include cosine theta. Thus, the angle is quite important when we're calculating the velocity. Ideally, we would like theta to be 0, having no effect on the velocity calculation. So what this means is that we would like to have the Doppler probe as in line with the blood flow as possible, either with the blood moving towards or away from the probe. You will see later that the probes on our system are quite small, allowing us to achieve very small angles, and we'll talk a lot more about this as we move through the presentation today. Here are some examples of what the Doppler signal looks like from various arteries throughout the mouse vasculature, and we will see later what signals look like within the mouse heart. Part of the validation work that we have done, which Dr. Reddy will discuss in a few slides, shows that these waveforms look exactly like those in a human, and they appear to at the appropriate times within the cardiac cycle. So here we can see a waveform and the monitored ECG signal coming below. As the blood flowing out of the heart into the aorta, we have very high velocities during systole, which you're seeing here, which drops back down to 0 during diastole. In fact, on the ascending aorta, which is this spectrum here, we're able to see a very small reversal in flow as the aortic valve is closing. If there was regurgitation, however, through this valve, we would see a much higher velocity in this reversal of flow. Using these markers within the different spectrograms allows us to be very reproducible about where we place the sample volume within the vasculature. As we move through the vascular system, we begin to see some diastolic flow as the vessels get smaller, moving closer towards the capillary beds, such as the renal arteries and the carotid arteries, as you see here. And one of the final spectrums of interest is the coronary artery. Here you actually see the flow shift into the diastolic phase of the cardiac cycle. Again, the ECG signal is on the bottom, and we can see that we're shifting it to the diastolic phase. As during contraction, the vessels of the myocardium do not fill, and it's only during diastole that we do see this flow. We can confirm this, again, because of the alignment with the ECG signal that we acquire. This is what the Doppler flow velocity system looks like. It includes the rodent surgical monitor that typically comes with two probes, one 10 megahertz and one 20 megahertz. And you can see here with the scale bar just how small these probes are. There are two hardware component boxes. The transceiver has two channels, which we will talk about later on, and the digitizer, which takes the signal and transfers it to the computer, which comes with the system. With these components, we're able to integrate with a number of other third-party systems. They would plug into these extra ports that you see here on the digitizer. These third-party systems may include a blood pressure system, any other type of physiological monitoring system which has a BNC connection, can be plugged in to the digitizer and would be displayed along the bottom panel of the software with the ECG signal. As mentioned previously, silicone cuff probes are available for surgical implantation and would be connected into the transceiver as well. We also discussed previously that both the non-invasive probes and the silicone cuff probes may be used to obtain Doppler spectrums on either anesthetized or conscious animals. The rodent surgical monitor system, sorry, I'm just losing my notes here. The rodent surgical monitoring system is heated, like I mentioned previously, to allow us to maintain the body temperature of the animal. This becomes very important when we're looking at cardiovascular function. As the temperature drops, the heart rate may also drop as well within the animal, and this may alter the results that we're getting. So this area that's darker here is heated. We then connect the paws of the animal, either the mouse or the rat, to these electrodes, and we're able to monitor the ECG signal, the respiration signal, and using a rectal probe, we're able to monitor the core body temperature as well. A few other key features of the Doppler flow velocity system, which allow it to be used on small animals, are listed here on this slide. Some of those include high temporal and spatial resolution, which are required because of mouse heartbeats upwards of 500 to 600 beats per minute. We also must be able to measure high blood flow velocities, such as would be experienced in the TAC or the transverse aortic constriction model. And we want to be able to minimize the angle, as we discussed before, between the probe and the blood flowing through the blood vessel. Additionally, being able to simultaneously acquire two signals from two sites on the animal will become important, and I'll explain this when we start to talk about pulse wave velocity. I'd now like to ask Dr. Reddy to take some time to discuss Doppler measurements across many species and why blood flow velocity is used to translate results obtained in mice right through to those observed in humans.
Okay, thank you, Tanya. Hello, everybody. One of the questions I want to talk about on this slide, and one of the questions that constantly arises, why do we need Doppler flow velocity? And when we should be measuring, what we should be measuring is cardiac output or something like that. So here is the table that kind of explains some of that question and answers that question, I should say. If you look at all the parameters on the top part of the screen, the heart rate, left ventricular volume, stroke volume, heart rate, cardiac output, all these are proportional to body weight. So that means as the body size changes, these parameters vary. So if you were to translate some of these measurements to other species, larger species, or even humans, then you would have a difficult time trying to do a direct translation. So if you come down to the lower part, the arterial pressure, aortic velocity, and pulse wave velocity are independent of body size. So if I were to give you, show you a blood pressure waveform without the timing scale, you wouldn't be able to tell whether it came from a mouse, rat, or human. And so same thing with aortic velocity and pulse wave velocity. So most velocities in vessels are independent of body size, and pulse wave velocity, which is used to define stiffness, is also independent of body size. So these numbers are very they don't vary across species that much, and so it will allow for a direct translation. Of course, arterial pressure is an invasive measurement, but we are talking about aortic velocity, which is a non-invasive measurement, and pulse wave velocity is also a non-invasive measurement. So I'll talk a little bit on the next slide about history of the application. You know, most of you probably know that Doppler has been applied to measure flow velocities about 6 decades ago, and it's considered a gold standard. It's been prevalent, used in humans and large animals for many years now. About 20 years, our group has published papers using 10 and 20 megahertz to measure peak flow velocities in mice, and we found that the flow velocity shapes the waveforms have very similar shapes as those as you have seen in the earlier slide that Tanya showed, and the timing of events within the cardiac cycle are very similar. And so our first paper was in 1995, validating these measurements in mice, mainly aortic flow velocity. And our second paper in 1997 validated the measurement of pulse wave velocity. We used a simultaneous pressure, tonometric pressure, to validate these measurements as well. And then the next, over the years, we have followed up with several different applications. A few of them are shown here. The last two applications, the last two papers actually describe the current Doppler flow velocity system. This is basically, the first paper is the design of the system, and the second paper discusses some of the applications. That was not the last. We have several other publications that are listed on the INDUS website, so for you to go. Thank you, and back to you, Tanya.
Excellent. Thanks, Dr. Reddy, for your insights on the blood flow velocity measurements, as well as the validation of our system. Moving on to a question that we get quite often, and that we'll spend a bit of time addressing here today. How does the Doppler flow velocity system from INDUS compare to an echo system specifically designed for small animals? And what are the advantages of using the Doppler flow velocity measurements? Let's take a very quick look at the comparison before diving into this question a little bit further. Both systems acquire data non-invasively. The Doppler system obtains measurements of flow velocity. While the echo system can also get flow velocity measurements, it adds the ability to acquire images on which dimensional measurements may be obtained. The Doppler system has a very small footprint compared to the echo system, and likewise, the cost is relatively low for the Doppler system when compared to an echo system. The probes, as we have seen earlier, are very small on our system, while they are quite large on the echo system, as many elements are required to obtain the images. We will talk more about why the probe size is critical for flow velocity measurements in many blood vessels. When we look at a quick comparison before delving into the answer a bit further, it's important to note that when we talk about the pulse wave Doppler system, we consider it to be complementary to the echo system. Both systems have their strengths, they have their weaknesses, but it's important that we choose the right tool to collect the most accurate data. So why is the Doppler system from INDUS more accurate than a traditional echo system? So we've talked several times about it. The smaller probes allow for smaller angles to be achieved between the probe and the blood flow velocity. For example, on the Doppler system, we often are working at 0 to 15 degrees, where the cosine of theta, as we remember from that equation, is quite small, where with the echo system, because of their larger size, again, they may have upwards of 256 elements to allow them to acquire an image. The angles that we're able to achieve when measuring a Doppler signal are somewhere around 60 to 90 degrees. So again, this is going to affect our velocity measurement quite significantly. Specifically, for the ascending aorta, coronary artery, and peripheral vessels, these small angles are much easier to achieve using the Doppler system when compared to the echo system. The importance of this, again, is that this angle can introduce significant error and can result in difficulty in reproducibility over a longitudinal study as we get above 15 degrees, again, because of that cosine theta within the measurement angle. As we look at the assessment of cardiac function with an echo system, this is typically measured using either M mode or B mode to provide measurements of ejection fraction or fractional shortening. The trouble here becomes the location of the measurement. If you're studying a disease model which has regional variations in function, such as myocardial infarction, then these measurements may over or underestimate the cardiac function and can lead to variability over the course of your longitudinal study. Doppler flow velocity systems, on the other hand, make the measurement at the aortic valve, and this takes into account all contractility of the left ventricle and is not affected by measurement location caused by the regional variability which may exist within the myocardium. We can identify the sample volume as being located at the aortic valve by the small reversal of flow that I showed previously within the spectrogram. This again is caused by the closure of the aortic valve. From the velocity spectrogram, one may also obtain acceleration, so either can be used to assess cardiac function. Another distinct difference of the Doppler system is that we can measure spectrograms from 2 Doppler probes simultaneously. This allows us to calculate pulse wave velocity in the most accurate way. Pulse wave velocity is the speed at which the pulse of blood travels through a specific vessel, for example, the aorta. This velocity allows us to assess the stiffness or compliance of the vessel. As the aorta, for example, loses compliance and becomes stiffer, either through disease progression or introduction of a drug or compound, we are able to assess this change, again, using pulse wave velocity. We take simultaneous measurements, typically one from the aortic arch and the other from the abdominal aorta, and we display these spectrograms simultaneously. So measurements made are on the same pulse of blood flowing through that vessel. This removes any variability which may be observed in the spectrograms that were obtained sequentially and then overlaid with one another. In this way, any variability introduced due to variations in the heartbeat, transient effects of drugs or other metabolites is removed. And when we display them simultaneously, we simply measure the time between the start of each waveform, as you can see in this blown up window here, and the distance between the probes on the animal, and we can quickly calculate the pulse wave velocity. Moving on to the next thing which differentiates the Doppler and the echo system. There's a few waveforms that prove challenging for some users on the echo system, specifically the coronary artery and the mitral valve. Not surprisingly, the coronary artery is challenging on the mouse as it measures around 200 microns. We have many customers who have purchased our system almost exclusively for measuring flow velocities through this vessel, looking at coronary flow reserve as an example. Also, obtaining a nice mitral valve spectrogram on a mouse is very easy using the small Doppler probes that we've discussed before. Here's an example showing both the E and the A peaks from a mouse, and here the heart rate of the mouse was actually 525 beats per minute. So again, we're able to separate the E and the A peaks quite nicely using the system. And finally, the last difference between the Doppler system and the echo system I will touch on is cost. The Doppler system is approximately 10% of the cost of the small animal echo system. This is because the probes are quite small, are far simpler, being small and having a single element, which is what's required for the Doppler signal acquisition, rather than a linear array of up to 256 elements, which is required for imaging. The Doppler probes are highly durable and low in cost if they need to be replaced. The electronics of the Doppler system is also far simpler, again, due to the single element which is used for the flow velocity spectrogram acquisition. And as mentioned, the footprint is much smaller, requiring less laboratory space for you to be able to set it up. We will jump now to discuss specific applications based on questions which came in. There were several overarching questions that came in about the data, such as what are the standard measurements used and reproducibility. We will address these questions as best we can for each application, while also answering the specific questions which relate to the area of interest. I'd like to start first with cardiac function. These questions surround how we measure cardiac function, can we measure flow in the aorta, and what are the benefits of using non-invasive versus invasive techniques. So first, systolic cardiac function. We've touched on this briefly a few slides ago, but again, we measure flow at the aortic valve. Here again, we can see that very small reversal in flow as the aortic valve is closing. This allows us to be reproducible in the placement of our sample volume for these measurements. We take the probe and we aim it up under the xiphoid process towards the base of the heart and locate the very distinctive aortic outflow velocity waveform as you see here. Typical measurements include peak and mean velocity along with acceleration. As we measure the ECG signal simultaneously with the flow velocity, we are also able to measure the pre-ejection time, ejection time, and other parameters that are of interest as well. Here are some examples of aortic outflow velocities from various models. As mice begin to age, here we have young and older mice, we see that the velocity slows down. Also of note here is that with calorie restriction, this diet does not help to prevent the decrease in flow velocity or decrease in systolic cardiac function. Let's keep this in mind for a few slides from now. A few other interesting models include the little dwarf mice that you can see here in orange, which happen to live 30% longer than their wild-type litter mates. Here we can see that their cardiac function starts out low, and other studies have shown that it remains low for the duration of their life. Similarly, with naked mole rats, which live up to 30 years underground, again, their cardiac function starts low and it remains low for the duration of their life. For diastolic function, we move the probe ever so slightly and look at the flow velocity spectrum as the blood flow enters the left ventricle from the atrium through the mitral valve. Here we look for the distinctive E, or early, and A, atrial peaks, which are indicative of the mitral valve. We also want a small amount of the aortic outflow to appear in the spectrum so that we can make some timing measurements. Typical measurements include peak velocities of the E and A peaks so that we can calculate the ratio between them. We can also look at acceleration and deacceleration rates and times. And finally, we're able to assess the isovolumic relaxation and contraction times, often used to calculate the TI index, which is a very common measurement of the diastolic function. Here we're looking at those same animal models as we did for systolic function, but now let's focus on the E to A ratio. Again, in aging, we see that the E to A ratio decreases. However, in this case, we can see that with the restricted diet, there is a protective effect in that we're able to maintain the E to A ratio with aging. If we look again at those little dwarf mice, we see that they have, again, a decreased E to A ratio, as do the naked mole rats. And again, this starts out early on in their lives and stays throughout the course of their lives. I'd now like to call on Dr. Reddy again to jump back in and spend a bit of time discussing some of the recent studies that he's been completing at Baylor. These studies look at aortic acceleration as measured with our Doppler system as a surrogate for left ventricular contractility measured using an invasive pressure catheter. Dr. Reddy?
Thank you, Tanya. We all know that the first derivative of left ventricular pressure is considered a gold standard to determine cardiac contractility. But again, pressure is invasive, and so over the years, attempts have been made to develop non-invasive methods to determine or estimate LV contractility. Here I mention a few studies. It was reported in patients, dogs, sheep, and rats. There may be other studies as well. Of all these studies we looked at, we found that the one in dogs had a high correlation to maximal DPDT. The equation was basically max DPDT is related to maximal du dt, which is U is nothing but aortic flow velocity. So it was non-invasively measured, and so we found, we thought that this would be a good way to validate our measurements for non-invasive determination of LV contractility. So moving on to the next slide, I'll show you what we did here. We put a catheter into the LV of the heart, and using a Doppler probe on the outside, from the skin, we measured these two signals simultaneously. So upper window shows the light blue waveform, which is aortic flow velocity. It's the actually envelope of the aortic flow velocity, peak envelope. And the lower window shows the left ventricular pressure that we measured with a pressure catheter. And so we got these waveforms and took derivatives of these waveforms, and the red one shows the derivative of the velocity, whereas the brown is on the lower window is a first derivative of the pressure, left ventricular pressure. And we compared these two. Now we also measured the mean acceleration of aortic flow velocity, basically by dividing the peak velocities divided by the rise time, or the time it took to go from 0 to maximum. On the next slide, I'll show you the data that we had these were obtained. This is some of the data from 6 mice. We had several data points, but I used the data points to go from 387. We had seen heart rates of 387 on the lower side at baseline, and we also gave dobutamine to get responses as high as 700 beats per minute on the heart rate. And you can see on the left side is the peak aortic acceleration versus the DPDT, and correlation is very high between these two. And on the right side, you can see the mean aortic acceleration, very high correlation as well. And so both these numbers, peak aortic acceleration, mean aortic acceleration, can be obtained with the Doppler system. And so these both seem to represent, at least in our initial studies, a pretty good estimation of the contractility of the heart. And moving on, I want to show you an example that even before we started these validations, the acceleration measurements have been published and used by many investigators, and I'm showing one example here between wild-type mice and ApoE knockout mice. And as you can see from the data below, in the table below, where peak acceleration at baseline was significantly different between the wild-type and the ApoE knockout mice, but mean acceleration was not. On the other hand, if you look at the graphs, after the administration of dobutamine, the mean acceleration showed significant differences between the groups. So it's already being used. What we are trying to do in this validation studies to look at all conditions. So in the next upcoming studies, we will be changing the loading conditions of the heart, and simultaneously looking at the LV pressure and velocity, and we'll present these results in a later webinar or in a publication that in a few months. So at this time, I would like to give the presentation back to Tanya and to continue our discussion.
Great, thanks, Dr. Reddy. Taking some time now to move on to the coronary flow reserve, we will discuss how this measurement can be obtained using our system. So as mentioned in our previous discussion, we have several groups who have purchased the system almost exclusively for assessing coronary flow reserve, and many publications on this application as well. The obvious challenges are the size of the artery and the movement of the heart. Using a micropositioner, as seen here, allows for fine adjustment of the probe position to obtain a very nice waveform. But it also allows the probe to remain in position while the heart is being challenged, either pharmacologically or by adjusting the isoflurane level to cause vasodilation. The coronary artery has a very specific shape to the spectrogram, as we discussed earlier, which again is also pushed into the diastolic phase of the cardiac cycle, all of which we use to obtain reproducible results for this artery. In this example, we use isoflurane to induce vasodilation in the coronary arteries. So we start at a very high level of isoflurane at 2.5%, and we wait for the highest peak velocities to be achieved. We then drop the isoflurane level down to 1% and watch the velocity drop, taking measurements frequently to ensure that we capture the lowest velocity possible prior to the animal awakening. These two values are then used to obtain the coronary flow reserve. Similar measurements may also be made using drug or compounds to induce vasodilation. The same technique may also be used in any type of surgical model, including TAC, permanent occlusion, or ischemia reperfusion models as well. The key here is to obtain the coronary flow reserve measurement before surgery so that you have the control of the same animal and can follow the progression over the course of your study. Moving on to vascular injury and pulse wave velocity, the questions asked were with regards to drug-induced vascular injury and the feasibility of measuring pulse wave velocity with only a single probe, which would require sequential measurements rather than simultaneous measurements, which we had discussed before. Changes in blood flow velocity caused by drug or compound-induced vascular injury can be assessed. An example here of ferric chloride-induced thrombosis, where Doppler was used to assess the time to occlusion. The reference is shown here on the slide. Additionally, changes in aortic stiffness can be assessed in various models. In wild-type mice, we see that the measurement of pulse wave velocity sits just under 300 centimeters per second. However, when phenylephrine is injected, the aorta stiffens, and the pulse wave velocity jumps to just under 1,000 centimeters per second. Of course, changes in various knockouts and animal models, as we see here, can also be assessed. As we discussed previously, pulse wave velocity is always measured at two sites. It is best to make these measurements simultaneously, as it is possible with our Doppler system, as you are looking at the same beat from the heart. Doing these measurements sequentially introduces many unknown variables such as changes in the R-to-R interval, changes in heart rate, for example, and most importantly, if you're looking at a pharmacological intervention, the transient effects of the compounds may vary between the two heartbeats. Here we look briefly at the difference between, again, sequential and simultaneous measurements. In sequential measurements, the same probe is used to acquire the spectrum from either site. So again, here the example is the aortic arch and the abdominal aorta. And we get two separate spectrograms. These spectrograms, again, are then overlaid with one another, aligning the ECG signal, and the pulse wave velocity is calculated. As stated earlier, the different pulses of blood are used to are observed in this approach. In simultaneous acquisition, as we discussed before, two probes are used, again, one at the aortic arch and one at the abdominal aorta, obtaining spectrograms from the two sites on the same pulse of blood. And we display them, again, simultaneously. So any measurement is made directly on a single spectrogram. For both, the distance is measured between the probes on the surface of the animal. And finally, I'd like to touch on the peripheral vasculature and some of the smallest blood vessels we've been able to obtain flow velocity spectrums on. It's quite difficult for us to say what the smallest blood vessel is that we can reliably obtain a flow velocity spectrum on, as there are many different vessels and many different models to speak of. However, to date, some of the smallest blood vessels that we've looked at are, for example, the coronary artery in the mouse, as we've described, and the saphenous artery in the mouse as well. Ideally, if looking to confirm presence of flow, we need approximately 5 to 10 centimeters per second of flow, while if we're looking for the pulsatility or resistive indices of that vessel, we would like to see flows upwards of 15 centimeters per second, just to make sure that our measurements are accurate and reproducible. Another example of small structures which we have reliably been obtaining flow velocity spectrums on is the heart of a zebrafish, as you can see here. Here we've been able to obtain flows from the ventricle outflow tract, seen here on the right, as well as which has flow going from the ventricle into the bulbus of the fish heart, as well as from the atrium into the ventricle of the fish heart as well. This is an exciting new area that we're working to explore further on and hope to have a webinar in the future to show these results. Thank you again for spending some time with us today, and I hope you've enjoyed learning more about the Doppler flow velocity system. Just to revisit what we talked about today, we looked at the overall system, addressing questions with regards to how our system compares to a small animal echocardiography system, and then just spent some time finishing up addressing questions about specific applications.
So the first question is, can this system help assess cerebral blood flow in regards to stroke? Perhaps, Tanya, I'll start by asking you to respond to that.
Absolutely. It's a great question, and it's a question we get quite frequently. And we've done some preliminary studies to show that we do get flow. We don't necessarily know exactly where that flow is coming from. So we've started a collaboration with another group to look at a model of middle cerebral artery occlusion and try to actually develop a protocol, an application note, so that other users can mimic the same thing. So we're starting that collaboration quite soon, and hopefully in the next couple of months we'll have an update and perhaps even do a webinar which would show those results and help share that information as well. Dr. Reddy, did you have anything else to add for that question?
Yes, Tanya. Yeah, this question has been on our minds for a long time, you know, because it's harder to figure out where exactly the vessels are flowing, but we're looking forward to getting these studies done. One of the things that I have done with a group where they were working on stroke models is basically they occlude the cerebral artery going through the right carotid artery, and essentially what they wanted to see was, do we have a flow on one side and not on the other side? And they suggested that I look at near the eye of the mouse. So what we were able to do was put the probe very close to the eye of the mouse, and able to focus on an artery. I'm not quite sure which one it is, but we do get nice flow. We did this on a control mouse on both sides and got very similar flows on both sides. And when we switched to the stroke model, one of the eyes, we couldn't measure anything from the same location. So this is very something very promising, especially to see if there was an occlusion or not. We definitely have to pursue this further to see exactly from where we are measuring what vessel, and perhaps establish this, like you said, you know, in future webinars, we may be able to shed more light on these measurements.
Great. Thank you, Anil.
Okay. Yeah, thanks to both of you, and thanks, Anil, for providing us with some information about that preliminary study that you're doing. The second question we have here is, how is it possible to separate the venous and arterial flow using the Doppler flow velocity technique?
Sure, I'll let Anil address that question.
Okay. The Doppler venous flows are always very little pulsatile, so they basically have a flat line type of shape of the waveform, if you will. Whereas arterial flows are very pulsatile, even in the smallest of vessels. They have some pulsatility component to it. So, for example, if you go to lower abdominal aorta and try to find aortic flow, it's very pulsatile, and just move a little bit to one side or the other depending on where you place the probe. You should be able to catch the inferior vena cava coming in. Likewise, we can also measure flows in the jugular artery, jugular vein, and of course carotid arteries. You have seen that. So most venous flows are pretty much flat line type of, very little pulsations. They basically look like a band going left to right, and but you do hear the sounds are like whooshing sounds, and whereas pulsatile flows, very distinct sounds from different vessels. I hope that answers the question.
Perfect. I'm sure it does. During the webinar today, a lot of data has been shown, obviously from mice. The question, our third question is, can this technology be easily utilized in rats?
Sure. So I'll start with that, and then I'll ask Anil to kind of add on to it. So as I was mentioning, we have the two different probes, the 20 megahertz and the 10 megahertz. And basically what frequency does, it affects the depth of penetration of the signal and our ability to look deeper in the animal. So that would be necessary for the rat. So depending on the size of the rat, I think rats vary more in weight and size than mice do in traditional studies. You would choose the probe which was appropriate for the size of the rat, and you would take a similar approach to the mice. Now, when looking at the heart, we can imagine the thoracic cavity of the rat is quite large in larger rats, say 500 grams, 350 grams, those types of sizes. So a different approach may be needed where with the mouse we come underneath the xiphoid process. We may come up closer to the base of the heart and come in through the intercostal space. Now again, this is where the size of the probes become very important compared to those of the echo system, for example. The probes are a few millimeters in diameter, so it's quite easy to get between the ribs to be able to get a Doppler waveform. Where with an echo probe, for example, the ribs often cause some shadowing and it's quite challenging at times to get the measurements that we'd like to see. Obviously with the peripheral vasculature, it becomes much simpler and we just again choose the appropriate probe and adjust our sample volume placement to match the depth of those vessels within the rat. And Neil, I'm not sure if you have anything else that you'd like to add there.
Yes, I would like to mention a few things that's notable for our system currently. Both the 10 and 20 megahertz probes, both of them are right now programmed to go up to 1 centimeter of depth. Of course, there's a pulse repetition frequency that we will talk about at a later stage. But what we can do in rats is all the peripheral vessels, we can still use 20 megahertz. And to use the 20 megahertz on the cardiac, we, like Tanya mentioned, we go in between the ribs and we can actually, instead of going from the xiphoid process, from underneath the xiphoid process, what we do is we go from the suprasternal border on the right side of the mouse and aim towards the ascending aorta, and we can get a nice ascending aortic flows. And if you go diametrically opposite to the left side and aim towards the mitral inflow coming in with the same probe from in between the ribs, we can get those flows as well. Once the procedure is established, of course, with some practice, you can pretty easily get those two signals. One of the things we will be doing very soon in the next several months is to change the range on the 10 megahertz probe where we can really double it to 20, because it is capable of going to at least 22 millimeters of depth. So we're going to double that. That way it can be used from the xiphoid if necessary for rats as well. So that should tell you that you can use it on rats. And if you have smaller sized rodents, you can use these probes on those as well.
Okay, perfect. Thanks both of you for that answer. And this might sort of lead into the next question, and perhaps you've already answered it. Jose has asked if it's possible to use frequencies less than 10 and 20 megahertz, and you've mentioned a couple times, Anil, that the paper is using the Doppler flow velocity system with 10 and 20 megahertz probes and how they're programmed for 1 centimeter of depth. But why is it that you chose those frequencies? What are the implications of using a lower frequency? And can you maybe talk a little bit about that?
Yeah. See, basically, the higher we go on the frequency, the depth of penetration starts to go down. So that means higher the frequency, lower the depth of penetration. But higher the frequency, the better the spatial resolution. So and I will definitely say that when you take a 20 megahertz and measure a particular signal, it looks much more sharper and crisper than a 10 megahertz, but doesn't mean to say that it will diminish any of the peak velocity. So we did comparison between the two, and we showed that there's absolutely no difference when it comes to peak velocity measurement with both probes. It's just like the visually one looks a little bit more sharper because of spatial resolution. But definitely when it comes to depth, the 20 megahertz at 62.5 kilohertz of pulse repetition frequency can go as deep as 1 centimeter. If we change that to 125 kilohertz, so essentially if we double that, it will cut off at 6 millimeters. So that particular setting is there on our current Doppler system. So if you set it to that, we usually use the 125 to measure the very high flow velocities that we see at in TAC banding models. So basically we're looking at the stenotic jet velocities that can go as high as, we've seen as high as 6 to 7 meters per second. So our system is capable of going up to 9. So that's where we switch from a 20 to a 10. Once it goes past 500, 49, I think it's 475 or something like that. If we go past that, we cannot use 20 megahertz. We have to switch to a 10 megahertz, and that will allow us to go higher. Okay. So there are a lot of interrelated stuff, but you can use frequencies less than 10. It'll allow you to go deeper, but on our system, we have programmed it just for 10 and 20. Okay, perfect.
Jose, hopefully that answers your question. And Tonya, was there anything else that you wanted to add to Anil's response?
As Anil kind of pointed out at the end, currently with the system as it's developed right now, we just do have the 10 and the 20 megahertz probes available at this time. So yeah.
Okay. Let's just ask maybe a couple more questions. Anita has asked, she mentions that they use very large mice, greater than 50 grams, in their cardiac echo experiments, and she'd like to know how the Doppler probes would perform with these fatty mice.
Sure. So why don't I take that one? So Anita, very similar to the rat approach, is we'd select the probe which gives you the signal of interest. So whether or not it's the 10 or the 20 megahertz probe would depend again on how much depth of penetration we needed for those mice. I presume they're the obese model. And whether or not you had to change the approach to similar with the rat, where we come up through the suprasternal notch view and begin to acquire those images. But as Anil was talking about, we're able to acquire the same cardiac and peripheral measurements on rats upwards of 300, 400, 500 grams. So a 50-gram mouse would just be treated as a large mouse or a very small rat. So it would absolutely be possible using the system.
And I would like to add to that. We have done several models, obese models up to 70 grams. Most of the fat is in the belly area. So for cardiac measurements, you still can go from the xiphoid and there's no issues at all. And so I wouldn't treat them any different than regular mice. If you go further down into the belly area, perhaps, but then again, fat tissue is soft, and so you can easily move things around when you're hunting for abdominal aortic velocity. Most of the time we use the abdominal aortic velocity for pulse wave velocity measurements where peaks don't matter, but then again, there may be other applications that you could use it for, but it's not a problem at all.
Okay. All right. And just to be cognizant of the time and respectful of everyone else's time, we'll ask one more question and then wrap things up. This is a fairly loaded question, but Shamim has asked how we, how do you ensure the proper location of the probe with regards to the vessel you're measuring? He goes on to mention that sometimes their models, or in their models, the heart is not in its normal position.
Absolutely. I'll start with this one, Anil, if you would like to add at the end.
Sure.
You can go for that. So talking about how the typical waveforms look like, I spent a bit of time talking about that aortic valve reversal of flow. So that's one way to know that you're at the aortic valve. And of course, with your animal models, if the heart's shifting, you do want to move the probe around and find that specific waveform characteristic, if you'd like. And at times, I know Anil was doing a training last week with a group that had an interesting model that we weren't familiar with. There's times where you may have to open the animal and be able to see what's going on. train yourself how to use that specific model and then continue forward with them non-invasively once you've kind of assessed what's going on with that specific model. So of course that would only be on 1 or 2 animals, and then throughout the course of your longitudinal study you'd be able to leave everything non-invasive. But it is a way to kind of train yourself on a unique model situation and one that you're not entirely sure exactly where to place the probe. I know.
Yeah, that's exactly right. Thanks, Tanya, for answering that. And what we have noticed over the years, whether it's a particular myocardial infarction model or TAC model or any other model, what will happen is you have very little space for the aorta to be moved after you have done something to the heart. And most probably it's the mitral that you may be talking about, that it might move in position, but the mitral timing and the shape is very distinct, so you will not be able to miss that. It may be not in your normal location from the xiphoid, but if you go move a little bit left and right, and one of the things that the probe allows you to do is, because it's so small, it's pretty much like hunting around, but knowing your regular anatomy in a normal mouse helps a lot, where exactly you would find this. So practice on a normal mouse and then going and finding these signals from a treated mouse or a mouse that has gone through major surgery is not too difficult to find. There may be special situations where you may have to initially locate that signal, if it needs be by invasive method, just to see where it is, and once you get a handle on that, then you don't have to do that for the next group of mice.